Well, our top story, could India be any sooner to getting a third COVID-19 vaccine? That's the big focus. Sputnik V, the world's first registered vaccine, has been peer-reviewed now by the Lancet Medical Journal and has shown an efficacy rate of more than 91%. Now, Sputnik V is being distributed here in India by Dr. Reddy's group, which is also conducting trials. Here's what we know about the vaccine so far. It's based on the human adenoviral vector-based platform. It's a weakened COVID virus that delivers parts of the pathogen, which triggers an immune response. The phase 3 trial is currently underway in India, UAE and Venezuela as well as Belarus. The trials in India are aged between 18 and 99 years of age. The trial size in India is around 1,600 participants. The trials are ongoing. And of course, after the phase 3 data is analyzed, they could apply for a license for emergency use authorization here in India. And it's important because it's the highest efficacy in a vaccine after Pfizer and Moderna. Remember, 91.6% is the efficacy that's being reported for the Sputnik V vaccine as per the Lancet Medical Journal. In terms of cost, also, one dose in the international market is going to be less than $10. It's a 2-dose vaccine and can be stored at 2 to 8 degrees, which makes it viable for India. So this, of course, is the good news that is in fact coming in. Dr. Rajesh Malhotra, the chief of COVID Facility Trauma Center, the All India Institute of Medical Sciences, joins us. We also have Professor Girdharar Babu from Bangalore, the professor and head life course epidemiology from the PHFI. Thank you both very much for being with us. I want to begin by asking you, Dr. Malhotra, how are you reading the news of the Sputnik efficacy and what does it mean for India?
So this Sputnik vaccine is based on the chimpanzee adenovirus, just like the Oxford vaccine. And this is the same vaccine, same principle, same platform which has been used for influenza. So we have known that this is a known platform, and this report about its more than 91% efficacy are really very encouraging. And we are really moving towards a time where the availability and accessibility for these vaccines, which are more or less equally effective, it seems, will be for everybody. So that's really good news.
Right. Professor Babu, how are you looking at these developments, and how soon, according to you or in your assessment, do you think that India can, in fact, now have a third coronavirus vaccine?
I think it's really a good news that the phase 3 results are published in Lancet. At the same time, the phase 3 is being carried out in India. And since there is a partner who will manufacture in India, I think in terms of availability of a vaccine within the market should be reasonably faster. But it still has to go through the regulatory approval in India, and only then it is in a position to be available in the vaccination program. I have had a look at the publication. I am confident about most of the results. There are some methodological issues, especially a large group of people not being assessed for adverse effects. I think with the Indian data, it will be much clearer.
Well, it's very interesting that we are talking about, this latest Lancet study on a day, Dr. Malhotra, that India has reached 4 million vaccinations in 18 days. This is, in fact, a record. And, would a new vaccine really boost our immunization attempts?
It will indeed, because not only it will boost our own in-house vaccination, but because we have an Indian partner manufacturing it, I think we are in a position to help the world, all our neighbors and all other countries which have been looking up to India to provide it with the vaccination. So I think on all fronts, even if gradually, as we keep on introducing more vaccines, our own need go down, right. But then it doesn't take away the advantage of manufacturing and giving it to the rest of the world.
Professor Babu, what's your assessment? While, of course, India's vaccination speed is touted to be record as far as, what's happening in the rest of the world, many say that we're still slower in terms of meeting our own targets. How soon do we need a third vaccine to boost our immunization effort?
I think that's a great question, because it's not just the availability of the vaccines. How fast do we cover the population is more important. In my own assessment, if we have to cover 300 million people in 3 months, that equals to vaccinating nearly 3 million people in a single day. So we are far away from what we have the potential in terms of achieving compared to what we are actually doing now. We can definitely celebrate, the faster vaccination coverage in India, but then in terms of potential, there is a great scope for improving.
All right. The other big story that we're tracking, of course, apart from the good news that's coming in on the vaccine front, is the news of India's active caseload dipping below 1.5% of the total number of cases. No deaths being reported in 14 states and union territories in the last 24 hours. But what we're also learning is, of course, the big question at the moment on herd immunity and whether these miraculous numbers, are, as many experts call them, is maybe because we're inching towards herd immunity. How are you reading Delhi's sero-survey? The 5th sero-survey, the overall sero-prevalence in Delhi is 56.13%, Dr. Malhotra. That almost means that half of Delhi's population has got COVID and recovered.
Yes, I think that's great news, and also that out of those 44 which did not show, there may be many who have had the infection, but then we know that the nature is not wasteful. So once the infection has come and gone, after 90 days or so, you may not find the antibodies. So the numbers of people exposed may be even larger than this. It has got many components to it which are great news. One is that we know that most of these people were asymptomatic, but then they showed antibodies, which again proved to us that asymptomatic people also show antibodies, which was an apprehension early on whether asymptomatic people throw an immune response or not. Having said that, whether it is sero-survey or vaccination or the talk about herd immunity, we have to keep in mind that those who are not yet vaccinated or not showing antibodies may not be protected, and we don't really know how many of these who are naturally infected the protection will last, because that still has to come. We don't know how many months or years the infection will last. So I think the complacency about the mask and hand hygiene and vaccination should not be there. There should be no hesitancy because of this.
So what you're essentially saying, Dr. Malhotra, is that neither the pace of our vaccination efforts nor this sero-survey data should make us complacent. We still need to follow COVID appropriate behavior, and that's an important point. But Professor Babu, how do you look at these figures? Because now many are making a very direct linkage between India inching towards herd immunity as a probable explanation for our numbers declining. Would you go so far as to make that correlation just yet?
I think it will be not completely reasonable to say the entire country has reached levels of population immunity. So the dense pockets in most of the metros might have reached the threshold for herd immunity, whereas in rural areas it is still present. The speed at which it spreads in the rural areas and other urban areas is relatively slower because of two reasons. One, the density will be much sparse compared to these metros. Two, the testing levels are also poor. So that doesn't mean that we are inching towards herd immunity. Yes, we are, but only in the dense pockets and in most metros. But let us also not forget, in Brazil, they had 55% of IgG in the first wave. And after that, they had a second wave, which was bigger than the first wave. So we have to be careful while we tread forward.
Right.
I always keep saying either the vaccine or the virus should reach more people faster. The option is to depend on the vaccine.
Okay, of course. Between the virus and the vaccine, we certainly hope that the vaccine is what reaches faster. But Professor Babu, I also want you to very quickly comment specifically on the numbers, because as far as the official figures go, 6,35,000 cases of coronavirus have been reported officially in the national capital. But if you look at the sero-survey, there'll be over 1 crore people, and as Dr. Malhotra said, even more people, because some antibodies tend to fade over a period of time. What does this tell us about the way we've managed coronavirus?
I think that's another great question. So even if you assume 1:10 ratio of reported cases versus the actual infected, Delhi should have reported nearly 10 lakhs cases, 1 million cases, right? So that means there is definitely missing of some symptomatic cases as well in terms of COVID-19 response. For every symptomatic case, even if we assume 0.5% as the infection fatality rate, 1 in 200 people might have had the risk of death also. So that means there might be an element of missed deaths reporting also. So that only reflects saying that the COVID-19 response in Delhi probably requires some introspection in terms of where the weaknesses are and how it can be actually strengthened as you move forward.
Dr. Malhotra, 10 seconds very briefly, are we then also to understand from this data that India has grossly underreported its cases?
See, the thing is, there's a difference between RT-PCR and antibody testing. So RT-PCR, people are reluctant. Initially, there was a stigma. People were not going. The test rates were to blame. So I don't think you can really equate the sero-survey results with RT-PCR. It can never work out that way in any country because there may be asymptomatic infections not tested, but they'll show up in the antibody test. There'll be inadequate testing, people not going for testing. So there will always be a gap which will be there, which is, I think, a universal phenomenon.
All right. Well, thank you both very much for joining us with your perspectives. It's indeed a very fascinating time to look at these numbers and, of course, the details of the sero survey as well. And we'll continue to examine this data very closely. Thank you both very much for sparing your time and being with us. Let's also now try and get in a perspective on how the world is looking at what's happening in India. Dr. Saad B. Omar, the director of the Yale Institute of Global Health, joins us for a quick comment on these developments. Thank you so much, Dr. Omar, for being with us. I want to begin by asking you, how do you look at Delhi's sero survey data? 56.13% sero prevalence in a sample size that's not small. The sample size is actually 28,000 people.
So it's one will have to look at the detailed data, but my sort of top line impression is that a lot of people got infected in Delhi, and there is the outbreak was fairly rampant. So the main question again is, what is the implication on herd immunity and slowing down the pandemic within certain regions with that level of seroprevalence? I would hold my judgment there because there's some intriguing data coming out from Amazon, from the Brazilian Amazon and one of the cities there, that suggests that even at high level of seroprevalence, we may not be seeing the level of herd immunity that we expect. Obviously, I think it will help slow down the infection if a high number of people are previously infected. But I think we need to watch this space a little bit more in terms of the exact precise implications on disease control. Nevertheless, at the end of the day, higher level of vaccination coverage, vaccine-induced immunity remains the right policy choice.
Right, but how do you look at these numbers from an India standpoint? Is India inching towards herd immunity? Would you say we're seeing, the world go through second and third waves of the coronavirus, whereas numbers in India are declining?
Partially, but again, there is issues of reinfection that are emerging, and data from elsewhere suggests that even high level of herd immunity, when you look at it, may not be sufficient. A high level of seroprotection may not be sufficient to induce sustainable herd immunity. So I think it could partially contribute to it. I think there are other factors as well. We have shown in some of our data, generally speaking, when there are higher rates, people do modify their behavior in subtle ways that can dictate some of the sort of follow-on infection rates and so on and so forth. So it's likely to be multifaceted. Unfortunately, there is less certainty around some of these issues than we would like to have.
Right. Let's just shift our focus to what's happening in the United States. For instance, the CDC has said that while cases in the US are down, 3 variants have been detected. Does that concern you?
It does concern me. So it's a mixed picture in that sense as well. So variants are not unexpected to spread in the US because we have seen again and again, even with travel restrictions, this virus and its variants come in and they spread fairly widely. So that's one thing that we need to know. The other thing is, for example, the UK and the South African variant, there is data that they are more infective in the sense that their efficiency of infection is higher. But once you get infected, the likelihood of mortality and severe outcomes is the same as the other one. But that means it has public health implications. A more widespread outbreak, even with the same mortality rates, is of concern. The second aspect is the good news for the sort of variants other than the South African variant, the so-called South African variant, is that the current vaccines seem to be sort of seem to have the same level of protection against these variants. There are some initial South Africa data, an increasing level of data, that seem to suggest that variant may be a little bit more impervious to the current vaccines. It doesn't mean that there will be no efficacy, but it seems that the efficacy of the current vaccines is likely to be somewhat lower against the South African variant. The good news is that there are a few more tools in our toolbox, even from, so other than non-pharmaceutical interventions, but even from vaccine strategy perspective, that could, in the medium term even, excuse me, that in the medium term even could ward off the more sort of substantial impact of these new variants that have routine doses that are less efficacious. So there are strategies that are being evaluated at this point. They're not ready for deployment, like booster doses, like strain change, like the way we do it for influenza and so on and so forth.
Well, because you talk about variants and vaccines, the other big story that we're tracking is the interim analysis of the Russian COVID-19 vaccine phase 3 trial. Now, data published in the Lancet suggests that it is 91.6% effective against symptomatic COVID-19. What's your reaction?
I think that this is very encouraging. So the more options we have globally and at the country level of vaccines and vaccine regimens, the better it is in terms of getting it out there quickly and to more people and different deployment and storage characteristics. So that this is really good news. One of the things a lot of us were watching for is peer-reviewed data from the Russian trials. So they had announced stuff, but we didn't have frankly a clear line of sight into their detailed data. Those data are now out. And the Lancet paper is fairly descriptive, et cetera, and that should reassure us that there is another highly efficacious vaccine out there that programs and countries and the world can use.
Well, Lancet has also, however, said that further research is needed to confirm results in those belonging to unrepresented risk groups as well as non-white ethnicities. Now, my question to you is, how do ethnic differences affect vaccine efficacy? Like for the United States, for instance, where this vaccine has not been tried, can you use the Sputnik vaccine?
So that's a really good question. This vaccine, since the US already has options for sort of highly efficacious vaccines already in its arsenal that are already approved, and where the bottleneck is the number of doses needed and, frankly, distribution system, it is unlikely to be sort of considered as an option in the US. Not because the data are not reassuring, because of several steps that are needed there. So it's likely to be targeted for other countries, including several, ostensibly high and middle income countries as well, not just low income countries. So that's that's the scenario in which we are working with this Russian vaccine.
All right, Dr. Saad Omar, Director, Yale Institute of Global Health, thanks so much for speaking with NDTV.